Hotbed Talk.
So it is my pleasure to introduce the chair for this session, who is Karen Kerr, the educational lead for poets, and she is joining us from Sheffield.
Well, good morning, everybody. Thanks for joining us in day one of EBPOM 2020. I'll thank the organisers for asking me to chair the first session. The first session is the Prehabilitation update. Now, I do hope that those that are listening just now have managed to find the time to watch the presentations ahead of today. I'm going to introduce the panel with abridged versions of the biographies. The full biographies are available on the EBPOM website. And if you watch the presentations in order, you'll have started with June Davis. Hi, June.
Hello.
Now, June's presentation title was Prehabilitation Guidance, Where Are We Now? June has been in the business of improving people for over 2 decades. It's an impressive self-evolution from dietitian to strategic and operational manager, research integrator and educator across the allied health professions. Her expertise is now assisting and leading the evolution of services, both regional and national. So June talked about prehabilitation for people with cancer, expanding on the guidance produced as a collaboration between Macmillan Cancer Support, the NIHR Cancer and Nutrition Collaboration and the Royal College of Anaesthetists. Now, in that presentation, June expands upon the prehabilitation principles, so please go listen. You have to encourage healthy behaviours, start early, screen, assess, optimise. And it's not just before cancer treatment, but also around cancer treatment and after cancer treatment. She asks us to think holistically when assessing these patients. Take homes from the session where that care is best personalised. It can be universal, targeted or specialised. And I do like that triangle that you show, both you, Denny and Steve, show that same triangle where you have your top being your specialised, then your targeted, and at the bottom being the universal. What was evident from the presentation is the ongoing consideration for going forward. And what's very impressive is SafeFit. I would advise everybody to see that presentation and to look on the Macmillan website regarding SafeFit. Put together in 8 weeks, a new approach to prehabilitation in new times. Next up, you had Professor Denny Levitt, Professor Lee Clinician in Perioperative Medicine. Now, she's talked about screening and assessment of physical fitness. It's an impressive CV that Denny has, both academically and clinically, researching in fields that she is professor and clinical lead in, such as anemia, prehabilitation and preoperative cardio-pulmonary exercise testing. And as Mike has already said, she's president for the association. Denny's talk starts with why physical fitness is important, not just for surgery, but importantly for life, irrespective of your ethnicity or your gender, with the biggest gains in mortality benefit being made in those who are the least fit. If you're going to modify, you need to screen, access and intervene, and Denny covers this in great detail. The MET study gets a mention, and if you haven't read it, it's probably worth a read. And Denny finishes with an update of COVID-19 and the pandemic before finishing with a summary slide. And then the final speaker is Dr. Steve Wooten, an Associate Professor in Nutrition. He's also to be found walking the streets of Southampton. He has an OBE for services to nutrition and physical exercise and is well placed to present in the final presentation, which was screening and assessment of nutritional fitness. Now, Steve starts with an exploration of what is meant by nutritional unfitness, and then he explores if it matters. There's a spoiler here because it does matter. Steve covers how an individual may become nutritionally unfit, the knock-on effects of being physically unfit, and then he goes on to provide more detail on the screening, the assessment, the diagnosis and management. Now, I know of the 3 topics, I know least about nutrition, so thank you, Steve. There are a number of take-homes from that presentation, a couple being that weight loss of at least 6% is actually prognostically a marker. The list of dietary impact factors is long, that the malnutrition universal screening tool is not the only screening tool, so I suggest you watch the presentation to find out what the other ones are. Find, feed and follow, used by Steve, I like the phrase, and the place for dietetic counselling, and actually that sarcopenic obesity does exist, and I've been right all along. Mike has already mentioned the use of Slido. I'll go to Mike first. Are there any questions before we start on Slido?
So, probably opening question actually turns out to be for Denny. Can you use TUG and DASI to screen out unnecessary CPET?
So the TUG refers to the timed up and go test, and the DASI is DASI, more commonly referred to, or the Duke Activity Status Index. It's a really good question because really what we're referring to is rather than doing a complex face-to-face assessment on every single patient that presents for surgery, is there a way that we can identify with our screening tool, which is after all what screening is all about, those patients who are both at high risk and need further evaluation, or are probably low risk patients who may be appropriate for universal interventions, exercise advice. One of the challenges is that at the moment, although we know that the gold standard for measuring aerobic fitness is cardio-pulmonary exercise testing, or CPET, we don't have a perfect validated tool with which to screen out or screen in low or high fitness individuals. And I think it's an area where there is a need for urgent research. In terms of activity questionnaires, and that's somewhere between just asking the patient what they do and doing a test, there are all these physical activity surveys. Of those, the DASI is the best validated in a surgical population. I would, however, mention a word of caution because the majority of the data is from a single study, which is multi-centre, which is reassuring and was a blinded prospective study. But I think we need greater data, particularly in the least fit patients, because the MET study data set, as I discussed in my talk, the patients are reasonably low risk. So we're not sure how good DASI is at identifying the very high-risk patient population, particularly because the low end of the score is not that low, and certainly in terms of our surgical population, our patients are very unfit. In terms of the get up and go test, timed up and go, that's standing up, walking 3 metres, turning around, coming back and sitting down. That was proposed to evaluate frailty and is part of the Edmonton frailty scale. It hasn't been validated in a multi-centre study as a tool to screen out, and it hasn't been directly compared against CPET. So potentially yes, but we need more data before we can confirm, is the test valid to approximate to exercise capacity? Does it relate to surgical outcome? And what threshold values should we be using to identify the patients we should be CPETing?
So it's not a question, Karen, but I have to air from Slido. Ross Kerridge, who many of you will know from the meeting in past years, he's almost always attended in person, says, "This is so cool, sitting in Australia and there are hundreds of friends and friends I haven't met all watching this together. Thanks all." So good start. Sessions of prehabilitation update. I just wondered if we're all clear what prehabilitation is. We've had a few discussions in the run-up to the meeting about where the scope is in terms of, is it just about exercise, psychology, nutrition? Does anemia creep in? Or actually, is it the whole preparation piece for surgery that we used to call preoperative assessment and intervention?
June?
I guess thinking about prehabilitation, it's the multimodal, so nutrition, physical activity and exercise, and emotional and psychological support as early as possible before an event, whether that be surgery, and think about it from an oncology point of view, also chemotherapy, radiotherapy, immunotherapy, and any combination, including surgery as well. I would also suggest that prehabilitation is a continuum to rehabilitation, so you cannot optimise people in advance of an event or treatment without a continuing support, and different people will have different needs as they progress through their journey. And I think that we need to consider all of those aspects as we think about prehabilitation in the round, and that it's more about the start of a journey. And it might be that we have to, particularly again with oncology patients, think about the fact that they will go through peaks, troughs, changes in their treatment throughout their lifetime potentially. And that really can set them up so well if they have support up front. I think in the system, we have a lot of support further down the line for people, potentially, but we have very little, and hence the significant growth of prehabilitation in this space to help support people much, much earlier on in predicting what they may have in terms of problems, managing symptoms, etc., as they go forward through their treatment and beyond.
Can I follow on and just ask, are you finding any particular cancer specialties are not engaging with prehabilitation?
Where you have successful services, Karen, is where you have good executive and clinical leadership. What is noticeable is in some places you have surgeons, anaesthetists and others who are particularly focused on particular patient groups. But actually, I've seen across the country people work with all tumour types at different levels, because different people have different needs, and then it links you back to your triangle, our triangle, I'm going to call it, the global triangle, which really matters in terms of where we place. So some of those patients in different tumour types will have different needs, some much lower level and some much higher level, as we know. But I've seen the most common are the, as you would expect, colorectal, breast, prostate and lung. However, some of the more, it's the Pareto effect, isn't it? It's the 80-20. So if you have more complex patients, I'm thinking head and neck, upper GI, etc., where actually there are perhaps smaller numbers of patients, but they need higher levels of interventions, then they are also patients that are seen. I think the issue is enabling us to have equity across the country, and appreciate we have international colleagues joining us across any system, because actually this can support anybody with any condition. And I think we need to be really cognizant of providing this as mandatory care, because we spend a lot on the drugs and the surgery and everything else, but this is quite low cost in the scheme of things.
Yeah. Can I ask Steve a question? I don't know a lot about nutrition, and I wonder whether or not I'm like the rest of the country in that I think a lot about exercise and I think a lot about the prehab, but I probably don't give enough time to nutrition. Is that common, or am I just an outlier?
No, I don't think you're an outlier, Karen, at all. I think over the last 40 years, I've spent an awful lot of time and effort trying to educate doctors around the importance of nutrition. For many doctors, it's a relatively modest part of their training. And because of our dietetic colleagues, very often there's a defer and refer principle at play. So rather than addressing it and taking the lead on addressing it, there's very often a case of saying, frankly, I don't know a lot, therefore I'll pass on to somebody who knows more. Whilst that's an important part of it, there's no doubt that unless the doctor takes the lead and takes responsibility for the care of the patient from a nutritional perspective, others will not follow. And we've seen that in screening and we've seen that in assessment. So to me, the critical thing is that we need everybody to be involved in managing the patient's, identifying the patient's needs and addressing them. And it may be that the doctor is responsible for the lead responsibility for the care of the patient, but clearly we need a whole host of other professions to ensure that that care is delivered appropriately. Our dietetic colleagues, our nursing colleagues, our speech and language, our therapists are all critically important in ensuring that that delivery occurs.
Mike mentioned at the very beginning that perhaps we have different definitions of prehabilitation. Do you think we all use the same language? Do you think if we did use the same language, we'd probably have people working better together? And if that's the case, who wants to lead?
Who wants to lead? I think from my perspective, nutrition has always been part of preoperative and pre-treatment care. We've got over 40 years of evidence accumulating about the importance of screening, identifying, find, treat and follow. That whole principle has been very much part of what we do. The challenge is it's always been seen as something separate from prehabilitation, which has been traditionally has been a very exercise-focused approach. What's coming out now, I think, is that really prehabilitation is about any modifiable risk. It's about treating any modifiable element, and that's why Mike mentioned at the beginning managing anemia or iron deficiency without anemia. There's a whole range of issues that we need to bring in together. And I think that's why we do need so many different people with different skills to work together. There is a question of who leads, and that's something which I think we'll explore over the course of this meeting.
We have from Southampton, which hopefully should be published reasonably soon, just conducted a national survey of perioperative medicine leads and what they are doing in terms of nutritional screening preoperatively and what their preoperative nutritional pathways are. And it's slightly depressing reading, I would suggest, in that more than 60% of them felt that they were not sure that there was a clear pathway for nutritional prehabilitation preoperatively. They all felt, though sometimes in specific cancer groups such as upper GI, there was a clear pathway with a dietitian assigned to a particular surgical clinic. On the whole, although must is being done on admission to hospital. Patients are not being routinely screened preoperatively and identified and are referred early. Interestingly, 90% of the perioperative medicine leads thought it was important, but less than 50% knew what their hospital pathways were. There is a huge challenge and there's a lot of work to be done. Certainly in Southampton, when we just did some baseline screening, 30% of our patients presenting for major surgery, which is in keeping with the literature Steve alluded to, are at risk of or were frankly malnourished at the time of presentation to the perioperative medicine service.
If I could just say, Karen, just to follow that, I think where we're very good at identifying people are those who are at the bottom end, the highest risk, and those who are most evidently in need. So from a nutrition perspective, the thin and wasted patient or the weight-losing patient is well recognised. What we're less good at is recognising everybody needs. And if somebody is of a normal weight or a higher weight, they may also have fitness issues, psychological issues, they may well have anemias, they may well have a host of nutritional considerations that aren't being picked up. So we've got to be careful we don't have a system that only identifies the most obvious. What we need to do is make sure all patients are assessed in all dimensions in order to be able to treat all patients.
The nutrition has been a bit of Cinderella, hasn't it? I don't think of you as a Cinderella, Steve, but the area is right. You know, it's where the easy wins are. I think we all get obsessed by exercise, but nutrition's relatively underinvested in. Sorry,
and I think part of that as well is the support for our dietetic colleagues. Having enough dietetic resource that's appropriately integrated into multidisciplinary teams who can provide that level of care, experience and care.
Also, I would say, Steve, directed at the right time in the pathway, because most of, certainly in tertiary care, most of the dietitian input is post-operative, and I feel that we're missing the window and probably then expending a lot of energy treating what might not have needed to be treated if we'd managed to get to them sooner.
Very much agreed.
Karen, it's worth saying that we did a survey of allied health professionals, including dietitians, nationally, about where people intervene in the pathway, and it just echoes what colleagues have said, is that 13% of those allied health professionals, so dietitians, speech and language therapists, physiotherapists and occupational therapists, 13% spend their time doing anything at and from diagnosis. Everybody else is treatment and beyond and palliative care. And I think that just highlights, and just going back to Steve's point, that actually we've just got just shy of 10,000 dietitians in this country for the whole population. So that's interesting in itself, in that where do we put that resource to best effect? Yeah, lots to do.
I sometimes find myself that perhaps because of the obesity pandemic we have, that people don't necessarily think that people are malnourished and nutritionally unfit. They just see a body. And I find it's hard sometimes to point out to my surgeons or bring their attention to the fact these people are actually not going to recover particularly well. And then add in the anemia and everything else. Yeah. June, you're talking about the work to be done. What is ongoing at the moment? Okay, there are 3 elements of work that are underway, and I'll just give you a broad view. So we've sort of set up grandly a cancer prehabilitation consortium, which is formed from the original partners that developed the guidance, and we've engaged with a whole host of other stakeholders. So there's lots of people have joined the party, rightly, actually, because there's such interest nationally and internationally in this space. So there's 3 elements. Service development and commissioning is one. So looking at what we don't know in this country is, certainly in the UK, is what are the prehabilitation offers nationally. So the plan was pre the pandemic, and it was just before we drafted a survey that was going to go out to all services across the country. That's clearly paused, but that will go out because we need to understand the prehabilitation and rehabilitation services, including the clinical and cost effectiveness that they offer to people. Because we're constantly getting asked, well, what are people doing in X, Y, or Z place across the UK? And we don't have that picture, not fully. We know what we know. So that's one point. So we had the guidance, but actually there needs to be clearer commissioning guidance and commissioning levers for some of this in terms of, well, how does this work get into practice? And a lot of it, we were talking recently, that it's very much a culture change program and service transformation. Money is very limited, so we have to think about how we use what we have differently. And I think there is a piece here around service transformation.
and the need for people in service providers, organisations to have implementation guidance. How do you do this? How, what, why, when, where, I think. The second strand of the work is around workforce, and I'm picking out some of the actions from the guidance here. So the second is around physical activity and exercise workforce. So thinking about it from the person's lens, from the patient's lens, if I go into a community gym, how do I know that I'm going to be safe and supported to exercise in a facility such as that? So with that in mind, we have had lots of stakeholders from all the relevant agencies get together to look at some of this and think, well, how do we look at the NHS workforce in the physical activity and exercise space and the wider physical activity community out with the NHS, and how do we develop that seamless transition for people? Currently, there are very few handoffs from NHS professionals into personal trainers and others, but actually there's a huge workforce there that could help support some of those people quite safely, whether it be remotely in current times or whether it be face-to-face. So there's a whole piece going on around what that looks like and how we have a proper accredited registers that may be don't have to be regulated professionals, but with accreditation attached. That's definitely very live and work ongoing. And the third piece is research, and there's a lot of work in this space. I think we were delighted, or I certainly was, and I'm sure others were, about the National Cancer Research Institute having, as part of their Living with and Beyond cancer piece, having prehabilitation as a clear box and work stream around research, which is the first time. Okay. And that's really exciting, actually, really, really great, because it means that there will be a focus in this space. There are some brilliant researchers, including many who are either at EBPOM or looking in, if you like, who are absolutely, world leaders in some of this. And there are lots of unanswered questions, but we have to focus on what are the research priorities. Some of it has been expedited as a result of COVID, clearly, and that's an opportunity amongst a crisis, to be fair, to help us. But there are questions that are still unanswered, and that goes across the nutrition, the physical activity and exercise space, and the psychological support and emotional well-being. So there are those three strands, and there's quite a lot of meat in each of those. But that's the summary, Karen, just to share.
Thank you. You talk about the workforce there. I wonder whether or not for nutrition there would be any way to get, because we seem to silo things, don't we? We have fitness, we have nutrition.
We do.
I wondered if we were...
As a fellow dietitian, this is dear to my heart, as Steve and others know as well. And I think what's interesting is, having talked to dietetic colleagues, it feels like we almost need to take, I'm not personally suggesting I do this, but others may, is that we look at the approach we've taken around the physical activity and exercise workforce and use the consortium and the work as a catalyst to get people to talk to each other. So it's the same when we talk about dietetics, nutritionists and others. We all have a role in this space, as well as support workers and others. And my personal view is we should look at that in the same way that we're looking at the physical activity and exercise workforce. And if we think about it from the person's lens, they don't frankly mind. They want somebody to be a one-stop shop and be able to sort them out. So I think we need to just think about that quite carefully. I think it would be really, really important to do, particularly because in the nutrition space, we have a different level of expertise of staff at different levels. And if we're going to staff the triangle with the workforce, we haven't got it currently quite right. It's certainly in the UK we haven't, and we need to do that work.
Karen,
I was going to ask. Sorry,
I'm going to be a wee bit disruptive because Slido is starting to quiver with questions, and particularly with COVID-19 related, very topical questions. But there's two dominant themes. One is around remote screening and assessment. So what if you're doing a remote service like SafeFit, which we'll hear about later, what's your best means of assessing particularly exercise but also nutrition? And then the second one, which will get everybody very excited, I'm sure, is CPET an aerosol generating procedure? So whichever one of those you want to chair in first, Karen.
We can go with is CPET an aerosol generating procedure. Denny?
Thank you for that slight hospital pass, Karen. So this is a hot topic at the moment, clearly, for obvious reasons. So POETs have issued some guidance on the website for those who are interested. You can link to that from the main screen and the expo on the website. But the absolute answer is we don't absolutely know, because there is not good data supporting whether it is or isn't. So nobody has done the study with a patient doing a CPET and looking at aerosolisation. So until somebody does that study, we will not 100% know. Having said that, there are other procedures which generate similar flows of gas and may cause coughing and spluttering, which CPET might do, that are designated aerosol-generating procedures. And so the majority of international bodies looking at cardio-pulmonary exercise testing and lung function testing, indeed, have erred on the side of caution for obvious reasons, because clearly there's a risk to healthcare professionals if they carry out tests without appropriate protection. So on the whole, the current situation, and it's the same view that Poets has taken, is that until we have clear evidence that it is not aerosol generating, we should treat CPET as an aerosol generating procedure, because the gas flows are high, we routinely do spirometry, you may evoke coughing, and currently in the UK from Public Health England, Optiflow, for example, and non-invasive ventilation are both standardised as categorised as aerosol-generating procedures and include gas flows that are of similar magnitudes. So that is the rationale for that. I cannot put my hand on my heart and know that there is good data that says that it is. So as a consequence, currently our recommendations are that PPE should be worn that is commensurate with it being an AGP. And in the UK, that guidance is given by Public Health England and would include an FP3 mask, a visor, gloves and surgical gown. The other big challenge for individuals running CPET in the COVID pandemic is if there is aerosol generation, then dispersal of that aerosol generation at the end of the test and ventilation within your laboratory. So after 6 complete air changes, the amount of aerosol left in the room is essentially negligible. How long that takes depends on the ventilation of your room, and that's why you would need to go to your local infection prevention team to ask them to evaluate that. If you are in a very well-ventilated lab, it may only be 20 minutes. If you're in a clinic room, that is likely to be in the region of leaving an hour between patients. And so necessarily, as a result, the efficiency of the service may reduce. People also ask, if you test patients for COVID prior to their CPET test, does this not mean that you could then downgrade your PPE? Unfortunately, we all know that there is a 10 to 20% false negative testing rate at the moment with oropharyngeal and nasal swabs. And this is not to do with the test itself, it's to do with sampling error. And so again, erring on the side of caution, that means that 10 to 20% of patients you're testing, even ones that are asymptomatic, because we know that asymptomatic COVID carriers may in fact still have COVID. And so, no, we wouldn't advise downgrading PPE on the basis of tests. As we move further through stages of the pandemic, and this will vary from nation to nation, it may be as the prevalence in the community drops, then we could take a more relaxed approach. But I think in the meantime, it's also one of our duties to perhaps do some testing to try and clarify this once and for all, whether this is an aerosol generating procedure and what the risk to the staff is. So I hope that clears up a difficult issue, even if the answer is not entirely satisfactory.
I think the second part of that was virtual screening in times of COVID and how are we approaching that? Steve, nutrition? For
SafeFit, we had a lot of discussions and working with our colleagues from the BDA, the Dietetic Association's Specialty Oncology Group, we've been looking at what evidence is available to us as to what we can use with confidence. Clearly, we don't have a large number of validated tests for all different settings or circumstances or conditions. But the test that's come out most consistently as of value is probably the patient-generated subjective global assessment. There are 3 key features of any screening or assessment tool that we might use remotely. One is to know what the current weight is and weight loss, their weight history. The second is to know whether they are weight losing because of impacts on their eating and drinking. So this is what we call the dietary impact factors or the nutrition impact factors. And the more symptoms patients present with, the greater the likelihood is they are going to be at risk. Those two elements alone probably account for most of the contributing factors in terms of identifying those at risk. And we're using that in SafeFit. There's a little shout from Mike there to remind me to say that's why we're using that one in SafeFit. Across oncology services, it's now being used more widely. What we'd like to be able to do is extend that and get some assessment of the degree of tissue loss or weight loss in terms of muscle and of fat. And in the full patient-generated subjective global assessment, there is what they call professional assessment. And it might be possible for us to actually develop a remote checklist that we can use, that the patient themselves can identify the extent to which they have these features. So that's looking for signs of lean loss and fat loss. So that's what we would recommend at this stage.
Thank you.
I think for the physical activity screening question, going back to where we were before, that we know that of these physical activity questionnaires, the DASI, which I alluded to earlier, is the best validated in the general surgical population. In terms of cut-offs, data is less clear, but from the recent MET study, a cut-off of 34 or less using the total index score rather than the calculated VO2 peak identified a group that were at higher risk of major complications after major abdominal and orthopedic surgery. So I think that is at least a starting point for triaging risk. You can generate from the DASI an estimated VO2 peak, which you can then apply to perhaps your own local data if you've previously used CPET, or in the absence of your own local data, published thresholds of risk. For example, a VO2 peak of around 15, less than 15, identifies a higher risk group for postoperative complications in most major abdominal surgery. So that is helpful, but a word of caution, as I said, from the MET study, the calibration of calculation of VO2 peak from the DASI index was not terribly accurate compared to an objective test on the same patient. And that's one of the research projects we'll be talking about later in the day that POET's hoping to embark upon shortly to try and validate that. But in the absence of anything else, DASI in the general surgical population would be the best validated questionnaire that we have to date.
There's a couple of questions, sorry.
Yeah, there's a very specific question about sit to stand 60, as whether that would be something that anybody's had experience of or could be used over a video call.
Well, I mean, yes, sit to stand 60 or timed up and go, those are very similar. So it's a measure for the very frail of how long it takes essentially to stand up or to walk a short distance. The challenges are, I'm more familiar with the thresholds than the timed up and go, but patients who are taking more than 20 seconds to stand up, turn around, walk and sit back down have been shown in one very small study to be at higher risk of prolonged length of stay that I mentioned in my talk. It's a very small sample, and so can we objectively say that the threshold X on the sit to stand definitely identifies the highest risk population? No, but it is better than just using clinical acumen, as in asking vague questions down the phone. What I would say is the problem with any of there are sort of three types. It's not great as a screening test. Number one, in COVID times, you still have to see the patient, although you're saying you can do it over video. A lot of our patients aren't able to do a video call, so we haven't had a lot of experience of doing that remotely yet. A questionnaire may be an easier place to start, and then that will maybe give you a very large group of more at-risk patients. So you could start with DASI, move to the 34 threshold, which in the MET study still identified a third of patients, so still a very large group of patients. You then may want to look at those who scored low on the DASI and maybe try something like asking the patient to do a stand up and go at home and seeing if they're below that 20-second threshold. But we don't actually really know exactly what threshold relates to what post-operative risk. It's a pragmatic approach, and I certainly think either of those would be perfectly rational and sensible things to use, rather than just asking a patient, what can you do? Because we do know quite clearly that that is neither accurate nor actually relates to any sort of clinical outcome in the most recent trials evaluating it. So I think my advice would be to start with a questionnaire, then you cut out a certain proportion of patients who are fit, and then with the less fit ones, you might try and do something a little bit more complex. Clearly, the minute you bring them into hospital, in the current situation, you are exposing them to an additional risk of COVID, and there's the issue of the 2-week isolation, so you want to minimise hospital visits. It's not to say that there are no patients that should come to hospital, but if you are bringing a patient to hospital, my opinion, if you have cardiopulmonary exercise testing available, is that will give you more information in terms of the cause of limitation and allow you to give a more accurate exercise prescription if it's available. So if the patient's already coming to hospital, I don't see an advantage of doing a simpler test if you can do the CPET, as long as you have the PPE available.
Thank you. There are some questions. There's a lot of commendation for CPET, but also some questions regarding being those digitally excluded.
Yeah, so good question, Karen, and we've been grappling with this, as you can imagine. So there is an option for people to have access through phone, and we have had queries where can clinical teams refer on the person's behalf because they don't have the technology to refer, even if that makes sense. So there are options where we can look at talking to somebody over the phone. Clearly it's not quite the same, but what we have found in the SafeFit model, of which we are all rapidly learning about, and you will hear more about it later from other colleagues, is that the intervention, which I would call it an intervention, of that initial assessment, screening and triage, is an intervention in itself for a lot of these people at this time. And it's proving quite profound in terms of what it's helping people to work through, because we're dealing with quite a significant amount of anxiety and distress in patients we're seeing. So I think that's also just worth knowing. And of course that they're primarily over the phone, those conversations. Certainly through Macmillan, we have the support line has the numbers, if you like, of people at Southampton who they can contact if they want to speak to somebody about SafeFit and don't have the technology, if you like, to do that. So we're trying to work around it, because clearly there are many people who don't have that access.
Can I just ask about psychology, in that it's part of the prehab package? We don't have a speaker for psychology. I take it Macmillan are well educated in it.
Well, so just to pick up, if I may, on the assessment and screening, the remote piece was the fact that we are using the distress thermometer, and we have an algorithm around the psychological support that people need. So a bit more than behaviour change, and understanding if somebody needs a high level of support, where do they go? So certainly within Macmillan, there is a service being developed which is going to provide high level psychological support. It's outside of SafeFit or anything else, but it will provide level 3, level 4 psychological support for people, for participants. So there could be a referral directly in. What is clear is that through certainly this remote offer, people can have the emotional psychological support bit, if you like, if they're not able for whatever reason, through COVID, etc., to exercise, or they may just need the nutrition component. So we should note that, because actually what's clear and what's coming through are people needing different things at different points. So the triangle is not linear. It's very dependent on what's coming through the virtual door, if that's the right phrase, at this time. And the other thing I should say finally is we're also using the electronic holistic needs assessment to capture people's holistic needs more broadly. So that's also quite important. So that's capturing anything from finance, work, housing, etc. And we don't have data currently, clearly, from what effect a pandemic has on people's holistic needs. We are now getting that because people are filling that in. So that is helping with the sort of holistic care that people are getting.
Karen, I've got another theme coming through strongly on the Slido, which is questions around, I guess, where prehab should be based, or who should be doing it. So for example, many of the components of prehabilitation would fall under the banner of normal GP care. How successful have we been at ensuring fit for referral? Where does that responsibility lie?
Yeah. So, shall I start, Karen? I think there's, as early as possible in the pathway, and a lot of what we're suggesting, particularly at a low level, and it's almost giving permission to people to do things for themselves and empower them and give them the resilience to do and help themselves. So that is absolutely primary care's place to help support that. Whether somebody has a confirmed or a suspected diagnosis, it does not matter. There is a fantastic model in Wales, and I know you will hear from Wales colleagues later, where they are looking at the ability to support people pre-diagnosis. And actually, for a lot of the advice that we're giving, it's health and well-being advice, which is not going to be harmful to the vast majority of patients. So it feels like we should absolutely engage our primary care colleagues. Primary care network works in this space, particularly as currently the system is people once referred and diagnosed go into secondary care and then don't come out and see their primary care clinicians until many, many months later. But actually there's an opportunity for them to be supported. And also we've been talking recently about, can some of this prehabilitation intervention piece actually be carried out in spaces in primary care, particularly as we don't really want people to go to hospitals. And because community centres and gyms are closed, could we use primary care facilities for that? My guess is we could, with the right precautions taken, where people need to be seen face to face. So that's also very recent discussions that have been had.
I think one of the problems is that sometimes people say it's not our job, it's their job. It's not tertiary care, it's primary care. And what will become clear as we hear some of the talks later today, and the longer you spend in this area, is that what we actually need, which is what we set out to do with perioperative medicine, is integrated care. And so that primary care can move seamlessly into secondary care. And so it shouldn't just be the premise of primary care. We need to work together. And although this should be absolutely the bread and butter of primary care, the reality is, certainly in the United Kingdom at the minute, is that these services are not readily available in primary care either, and these pathways have not been set up for primary care. And the really important work that June was talking about after the guidance, where focusing on the workforce and who can deliver this locally, once we've identified that workforce, they can deliver exercise training not only for patients for prehab, but also, for example, patients with chronic medical conditions, heart failure patients, COPD. And that work would clearly be an integration between primary and secondary care. I think we all need to work together to make sure that there's a pathway for a patient to get evaluated as early as possible. And in different regions, it may be a different individual, and I think we'll talk about that later when we look at some of the models in the UK. Very different groups have set up the initial prehab pathways, and I think we'll talk about some consistent themes, which seem to be that patients would ideally like to be engaged in these activities close to home. And we know from the psychological work around behaviour change is that the change is much more likely to persist after the acute event if it becomes an active part of that patient's lifestyle, and that's much more likely to take place if the facilities to continue afterwards are close to home and something they can integrate into daily life rather than attending a hospital, which may be many miles away.
It's a shame that we're talking about this in terms of patients, because as Denny showed in her presentation, that actually fitness is affects life, so the least fit actually have the highest all-cause mortality. And June, you've mentioned how actually even if you didn't progress to have a cancer diagnosis, if you were engaged in all this, it would be for your benefit. And it's the same with Steve. If you were to spot and tell people early just how to improve things, they could be improved. So maybe we need to focus on engaging with primary care. Now, Wales, I think, have got a good system. What about England? Are we finding that we're getting engagement from primary care?
I think we are more so, Karen. I think we are. And I know as we've sort of gone on this journey, and it is a bit of a journey, we have engaged more with public health colleagues as well. So you will hear, I think, from some teams later where they have engaged with the local public health teams in the local authorities, etc. So much more positioning it in the public health space. I think the problem with that is that we have to get this mainstream, and it's how much do people need support versus how much can they be. It goes back to this supported and self-management piece and making every contact count and all of that, which is everybody's responsibility who works in health and care, whether you're in the NHS or out with, really. And I think we have work to do, and I would absolutely agree with Denny that this is an integrated approach. This is not about one person's or one system's part of the system's responsibility, but we need to, ultimately it needs to be in policy, and it needs to have commissioning levers, and it needs to link to contracts in order for it to happen. I think that's certainly my personal experience. That's how stuff happens. So, that matters.
Aaron, I think we're having too much fun because it appears that we're coming up to the hour. So I will leave it to you to say that.
We'll just carry on talking, don't worry.
Just fade it out. Well, I'd like to say thank you very much then to all our speakers for what I think was actually a very good first session on the first day.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.